Today I'm going to be talking about anaphylactic shock. At the end of this presentation, you should be able to diagnose anaphylaxis confidently, appreciate the pathophysiology behind it, and learn to manage anaphylactic shock well. Within the next few slides, we would be talking about the definition and diagnosis of anaphylactic shock, criteria for diagnosing anaphylaxis, the basic pathophysiology, and also run through management principles. Anaphylaxis is defined as a serious, life-threatening, generalized, or systemic hypersensitivity reaction. The diagnosis of anaphylaxis is clinical. A detailed history is essential and should be taken. In particular, looking out for a sudden onset of characteristic symptoms and signs within minutes to hours after exposure to a potential trigger, often followed by a rapid progression of symptoms and signs over hours. The diagnosis of anaphylaxis is based on clinical findings as shown in the subsequent slide. Anaphylaxis is likely when any one of the three listed criteria is satisfied. The first criteria includes acute onset of skin and/or mucosal tissue involvement, such as urticaria, itching, or swelling of the lips, eyes, or uvula, with either respiratory compromise or hypotension, or symptoms of reduced end organ perfusion, such as syncope. The second criteria includes rapid involvement of two or more of the following systems that occur rapidly after exposure to a likely allergen. This would include A. Skin or mucosal tissue involvement, B. Respiratory symptoms, which would include shortness of breath, stridor, wheezing, hypoxemia, or reduced peak expiratory flow rate, C. Hypotension or symptoms of reduced end organ perfusion, or D. Persistent gastrointestinal symptoms such as abdominal pain or vomiting. The third criteria includes hypotension after exposure to a known allergen, defined as a systolic blood pressure of less than 90 or greater than a 30% decrease from baseline. Understanding the pathophysiology behind anaphylaxis is essential. There are multiple possible triggers of anaphylaxis. Common triggers include food allergies, insect stings, and medication allergy. Idiopathic anaphylaxis, where no trigger can be identified, is also a relatively common cause. Other possible triggers include contrast media or dyes, occupational allergens such as latex, or even seminal fluid. Such triggers result in a rapid release of pro-inflammatory and vasoactive mediators and cytokines from the degranulation of mast cells and basophils. These include histamines, prostaglandin D2, leukotrienes, platelet activating factors, nitric oxide, etc. The effects of the mediators and cytokines released on organ systems lead to the clinical manifestations of anaphylaxis. Possible mechanisms behind anaphylactic events have been delineated by the World Allergy Organization into immunologic mechanisms, which may in turn be IgE dependent or independent, non-immunologic mechanisms from direct mast cells activation, and also idiopathic mechanisms where no apparent trigger is identifiable. Anaphylaxis is a medical emergency and prompt intervention must be instituted after recognition of the condition. As with all emergent conditions, airway, breathing, and circulation must be assessed and stabilized. The airway should be assessed for evidence of angioedema causing mechanical obstructions, such as edema of the tongue and uvula. Early intubation may be needed if the patient is in respiratory distress or is unable to maintain his airway, as delay may result in airway obstruction secondary to worsening angioedema. Removal of trigger exposure, if possible, should be carried out. Provide an intramuscular injection of epinephrine for the patient. More details on epinephrine administration will be discussed in the next slide. Position the patient appropriately in a supine position with lower limbs elevated. Note that the patient may be unable to lie supine when there is a presence of airway compromise or vomiting. The patient should be managed in a monitored area with frequent monitoring of vital signs. Provide supplemental oxygen and start intravenous fluid resuscitation. Epinephrine is used in management of anaphylaxis as it acts on both alpha and beta adrenergic receptors. At the alpha-1 adrenergic receptor, it increases vasoconstriction and vascular resistance. At the beta-1 adrenergic receptor, it has both chronotropic and inotropic cardiac effects. At the beta-2 adrenergic receptor, it reduces bronchoconstriction and decreases mediator release. This results in increased blood pressure, reduces respiratory compromise, and decreases symptoms from involvement of mucosal edema. Epinephrine is dosed at 0.01 mg per kilos of 1:10,000 solution, with maximum of 0.5 mg per dose in adults. Doses may be repeated up to every 5 minutes as indicated. It is given intramuscularly to the mid-anterolateral thigh to provide rapid absorption into central circulation. Slow intravenous epinephrine infusions may be given if the patient is in shock. Intravenous bolus epinephrine may be given in the event of cardiac arrest. Common adverse effects of epinephrine administration include tremor, anxiety, palpitations, dizziness, and headache. Serious adverse effects include ventricular arrhythmias, hypertensive crisis, and pulmonary edema. The use of second-line medications in the initial management of anaphylaxis is mainly extrapolated from the use in treatment of other conditions, such as urticaria or acute asthma. There has not been any conclusive evidence for the use of these second-line medications in management of anaphylaxis. Do not delay administration of epinephrine. Second-line medications may be given after epinephrine has been administered. Antihistamines include both H1 and H2 antagonists. They decrease symptoms of skin and mucosal involvement, but also have the potential side effects of hypotension, which may further worsen anaphylactic shock. Beta-2 agonists such as nebulized salbutamol may be given to patients with lower respiratory tract symptoms of wheezing and shortness of breath, despite epinephrine administration. Glucocorticoid administration aims to decrease the pro-inflammatory state triggered by anaphylaxis. They have a delayed onset of action, but that may have a role in protracted anaphylaxis and biphasic anaphylaxis. In patients with refractory anaphylactic shock despite optimal initial management, escalation of therapy should be considered. Intubation, if indicated, should be carried out by an experienced personnel due to the potential of the high likelihood of difficult airway, especially in patients with soft tissue edema of the upper airway. Intravenous vasopressors may be started in patients with hypotension refractory to intramuscular epinephrine and intravenous fluids. Dosage of vasopressors should be titrated to clinical response. In patients with anaphylactic shock who are on beta blockers and not responding to epinephrine, glucagon may be administered for its chronotropic and inotropic cardiac effects. Similarly, anticholinergic agents such as atropine and ipratropium may be administered in patients with persistent bradycardia and bronchospasm respectively. Biphasic anaphylaxis is a phenomenon in which symptoms recur up to 72 hours after the initial symptoms have resolved. It occurs in up to a quarter of patients with anaphylaxis. There has not been any clear guidelines with regards to the duration of observation after the resolution of symptoms. Duration of observation should relate to the severity of anaphylaxis, with 4 to 6 hours for patients with mild cardiovascular or respiratory manifestations, and admission for monitoring if manifestations were severe. Discharge considerations are as follows. Discharge medications should include a course of oral antihistamines and steroids, to decrease the theoretical risk of biphasic reaction. Prior to discharge from the ED, after an episode of anaphylaxis has resolved, patients should be educated about their condition and advised to avoid triggers. They should also be educated regarding symptoms and advised to return immediately if unwell. They should be discharged with an appointment to the allergy clinic for testing and confirmation of their allergy within the next 1 to 2 months. They should also be provided with a medical identification card which states the diagnosis of anaphylaxis and triggers, if any. In summary, although anaphylaxis is a serious medical emergency with the potential for rapid and acute deterioration, with the understanding of the pathophysiology behind the condition, we can identify and provide appropriate management. It should also be emphasized that intramuscular epinephrine should be the first-line management in patients with anaphylaxis. You should also be aware of the potential for biphasic reaction to occur and counsel the patient appropriately prior to discharge from the ED.